Is everybody able to see my screen
Yes,
and not the presenter view?
correct.
Perfect. All right. So my name is JD Duhamel. I'm a third year resident at University of Missouri. So I want to talk about pediatric airways as you guys voted on. I'm looking to go into pediatric emergency medicine. So this is something that's important to me. And I'm hoping to make it a little bit easier for everybody else. So we're going to go ahead and start off with a few cases just to get everybody prepped for what we're going to talk about. So feel free to put your answers in the chat or anywhere else. But we're going to start out with a 3-month-old with worsening nasal congestion, cough, respiratory distress over the past 4 days. As this all been happening, the child has been more lethargic, working harder to breathe with lots of retractions, including tracheal tugging. So as we get vitals, blood pressure is a little bit softer, heart rate's pretty fast. We're breathing really hard and really fast, and we're a little bit low on our oxygen saturation. We're also febrile. So what are kind of three immediate interventions we can do in the interim? So kind of for me, what I look at in this situation is we need to kind of address all different roots of the aspects of everything going on. So we do have a fever, so we can start with some antipyretics to help deal with the nasal congestion, especially in our infants who are obligatory nose breathers. Some nasal suctioning will work really well. And then if we're still having difficulty breathing afterwards, we can start heated high flow to help with the oxygen exchange at this time just to support them from a respiratory standpoint. So for our next case, we're going to do a 10-year-old who's brought in after a bicycle accident. He's obtunded with a GCS of 7 and has bleeding from the mouth of snoring respirations. So what airway intervention should we do immediately?
Feel free to chime in either in the chat or out loud to Dr. Duhamel's questions.
Yeah, so Carly, yeah, he needs intubation. The rule of thumb is less than 8 is intubation. So we should do some immediate intervention for airway protection. If we're concerned about a brain bleed or injury to the head, we should elevate the head of the bed and probably over respirate them to minimize their CO2. To help with intubation during this, we do have some head trauma and other stuff, so we do want to stabilize C-spine if we are doing an intubation. For case three, we have a 2-year-old kid who has a sudden onset of stridor and respiratory distress. He was playing in the other room away from parent supervision. Before this, he's had no fever or cough, but comes in somnolent and is in respiratory distress. So what are some immediate maneuvers we can do to try to fix the problem? Yeah. So we can search for a foreign body either in the mouth or we can also try some back blows or abdominal thrust. So try to do back blows and chest thrusts in our kids who are less than 1. Afterwards, you can try doing some abdominal thrusts, but it's more of just figuring out what's the perfect situation for the kid. So what are any sort of special tools that we want at bedside if any of our maneuvers fail? Yeah, I mean, a crike kit could be useful if we can't get anything out, but are there any other tools that might make it easier if we are suspecting a foreign body to get it out? Yeah, so some sort of forceps, like McGill forceps, who are a little bit longer, so we can grab whatever tools there. If we have any sort of ENT or even a scope to see where exactly it is, that might be beneficial as well. For our fourth case, we have a 4-year-old. They have a history of severe asthma. They're presenting with severe respiratory distress, lots of accessory muscle use. Their oxygen saturation is low, and we've been trying to do some inhaled treatments for the kid. The kid is tiring out, becoming drowsy. What are things we worry about in the clinical vignette that would suggest the impending respiratory failure for this kid? Yeah, I mean, accessory muscle use is kind of our last resort for compensating for everything. Our oxygen saturation is low. So pretty much anything in this case is suggesting that the respiratory failure is here. But for me, what worries me the most is becoming drowsy. We know that the drowsiness is probably from a rising CO2 level, which is going to cause the altered mental status and more indicating that the kid's no longer able to compensate for what's going on. So like what are some considerations for this kid that we need to think about before intubating the patient, especially in a kid with asthma? Yeah, exactly. Nebulized. So we have lots of air trapping going on just because of the bronchospasm. So making sure we're doing as much nebulization as possible. Gina talked about magnesium, which is definitely something that we should be doing to open up the airways. Even some IM epi to open up everything. In terms of our medications when intubating with asthma, ketamine, besides also um, sedating the patient also reduces the bronchial spasms. And if we are able to intubate this kid, we want to make sure we're prolonging the expiratory phase and we're okay with a little bit of high CO2 in the meantime. But essentially, the main teaching point for asthma kiddos is intubation is a last resort. Any sort of asthma kid who needs to be intubated increases the mortality. So we really want to optimize them before intubating and use that as a last resort. So for our last case to begin with, we have a 14-month-old kid who has stridor and respiratory distress. We initially see them where their heart rate's really high, they're breathing high, and their O2 sat is low. We already tried doing racemic epi, we tried IV methylprednisolone, and supplemental oxygen with no improvement. We're going to intubate them, and we see this large obstructing hemangioma that's present in the airway that precludes us from intubating the kiddo. What is kind of our last resort for him? Yeah, exactly. Call all of our friends, call anesthesia, call our ENT people, get as much help as we can. In the meantime, if we are unable to ventilate and we're unable to oxygenate the kiddo, then we'll probably need to do a needle cricothyrotomy. This is just a last resort situation where we can oxygenate the kiddo, but we're unable to really ventilate with high enough properties to do that. But it's a good stabilizing measure in the meantime. So we'll go ahead and get started with the full presentation after these warm-up cases. So just kind of an overview of what we're going to talk about. We're going to talk about the physiologic and anatomical differences between pediatrics and adults. They are small human beings, but their physiology and anatomy is very different. We'll talk about positioning, which is really important in kids, how to select the correct tube and what stuff we'll need for intubation, different rapid sequence medications, as well as sedating medications, how to actually intubate in terms of different blades and techniques, how to troubleshoot when we get to problems, and what our advanced airways and last support measures are. So we'll go through all of this, and we're going to be talking with a central case. So we have a 2-year-old boy who's coming into the emergency department. He's had multiple days of fever, stridor, and a barking cough. And as we see them and assess them, we know that they're going to need intubation for impending airway obstruction. So, to start off with our physiology, it's important to know that children have less physiologic reserve because they're shifted because they're increased oxygen use. Because of this, they compensate in different ways. Kids at baseline are going to compensate by breathing faster and not harder to compensate for everything. They have less functional residual capacity, so they tend to desaturate quicker and have additional stress on other organ systems, why kids tend to be bradycardic quicker than adults when they have lower oxygen levels. Kids and especially infants have higher oxygen demand. Infants compared to adults have nearly double the amount per body weight because their underlying metabolic rate is much quicker. Because of this, they desaturate quicker whenever they are apneic as well. Kids have different compliance where their thoracic cage is soft. Their chest wall is more compliant because it's composed of more cartilage and less bones. So they're more reliant on their diaphragm to move air. Because they also have smaller airways, it leads to higher resistance compared to adults, meaning that it's harder to even move air with their more compliant tissues. And then also, it's important to remember that infants are obligatory nose breathers. So any sort of nasal obstruction, upper respiratory mucus can impact our pediatric patients more than our adults. And so we talk a lot about we talk about how neonates are obligatory nasal breathers, but no one really talks about why. There's this idea of the neonatal paradox. So, for example, a 3 kilogram newborn is going to have a tidal volume of 15 milliliters. In terms of their extrathoracic dead space, it's going to be 9 mLs, and their intrathoracic dead space is 3 mLs. So, whenever a kid breathes, they're only using about 3 milliliters of their tidal volume that's actually going to be functional within the alveoli. And so, how exactly do the neonates um, make up for this is we see a picture on the left. It's comparing the far left of that picture is a neonatal breathing pattern in the airflow within their nasal pharynx compared to the right, which is an adult. So because of this, the airway is designed so that they have higher flowing vortexes, so it makes up for the fractional inspired O2. So they actually exchange the CO2 and oxygen quicker because the airway is moving faster. And I think it's important to recognize on the right is the flow within a high flow nasal cannula. And so essentially, we're doing that to mimic the breathing mechanics within newborns. Even in adults, you're leading to these higher vortexes, so you're able to exchange the oxygen quicker. And that gradient between the lower FiO2 and the bottom of the lungs is going to be much quicker and easier to flow through compared to the higher one in the nose. And so, leading back to our central case, what is kind of our differential diagnosis in this 2-year-old kid with barking cough? Yeah, yeah. So it's going to be croup is the main one. We also want to worry about like epiglottitis or inhaled foreign body in our younger kids with striders, but considering the clinical course of this barking cough, and fevers going on for 4 days, it's probably going to be croup. So in this kiddo, why are we having respiratory failure? Yeah, I mean, whooping cough is another good one too. Yeah, a little bit of edema. Yeah, exactly. Edema of the airway. So by the actual swelling and inflammation, you're going to be causing more of an obstruction. So we're not actually able to ventilate as good as we can. So it's not necessarily an oxygenation problem. So for this kiddo, what resuscitative measures can we do prior to intubation? Yeah, exactly. So racemic epinephrine is going to be great. Steroids are also going to be another one, but remember it will take a little bit longer to kick in and work. With the epinephrine, we're not doing it more to give the kid the actual adrenaline effects of the epinephrine, but it's more to decrease the swelling to minimize the obstruction. For these kiddos, we can also do high flow nasal cannula to help better with ventilation, and we can even do to BiPAP just to increase the ventilation as well. So going on to our anatomical differences, within the head and neck is a big variation between kids and adults. Kids are, again, obligatory nose breathers because that nasal obstruction um, can lead to more impaired respiration in those populations. Kids also have a large occiput compared to adults, so that really impacts our positioning in terms of optimizing the airway. Kids also have a proportionally shorter neck, so whenever there's any flexation of the neck, it really impairs our airway obstruction. Hence why a lot of people use towel rolls to extend the neck to open it up. In terms of the actual mouth and larynx, kids have a disproportionately larger tongue, so that can impact their actual breathing in terms of obstruction, but it also makes it harder to do any direct visualization. The epiglottis in infants is more U-shaped. It's longer and it's also stiffer proportionally. The larynx also lies higher within the neck, so it creates more acute angles, making it harder to visualize. In kids, the narrowest part of the upper airway is actually through the vocal cords and not at the cricoid like it is for adults. So that impacts how we do our tube in terms of is it going to be cuffed or uncuffed? And we'll discuss that a little bit later in the presentation. For our intrathoracic differences, the intrathoracic trachea is much shorter in kids. So if we do place an ET tube, we're only going to have about 4 centimeters of difference in terms of our margin for error for the tube placement. So making sure we have our calculations right to select where the tube should end and how deep it should be is going to be really important. Um, Also in kids, the angles between the bronchi are much similar and not as different. So you have an equal chance of doing a left main stem versus a right main stem in kids. So it's something to be aware of if we listen afterwards and we're only having one-sided breath sounds. In adults, I think if I intubate a patient and it's more of only doing the right, I'm worried more about the right main stem. And more of if it's the other side, I'm thinking, did I cause a pneumo or other sort of lung things? But in kids, just remember to retract the tube if we're having even on both sides. And always thinking about doing left main stem when adults is only right. The airways themselves are again much narrower, so there's more resistance, so we need much higher flows to compensate for anything. And so when it comes to anatomy, we need to recognize when to anticipate difficult airways. I use the same acronym for adults as I do for kids, and to make sure that I'm not missing anything. So I use the acronym LEMONS on how to identify what could be coming. So the first L is to look for any external indications that it could be a difficult airway. That comes to kids with any sort of facial trauma where we're having bruising, blood in the mouth, if there's any sort of abnormal development where we have cranial facial abnormalities. It's especially noted in kids that most of the times that they're corrected in stages, if they're corrected at all. And no two kids are going to be identical just because everything can form differently. We also need to evaluate the mouth opening. Is this a kid who has had jaw trauma in the past? If they are spastic and we can't get the mouth open, that can be an indication that it's going to be a more difficult airway. In terms of our mouth, we also need to check for tongue size, especially in kids with Down syndrome. Our tongues are going to be much bigger and can lead for harder blade insertion. Remember obstruction signs, especially in kids. Are we having any sort of stridor? Are we having any large tracheal tugging? And those can be an indication that it's going to be more of a lower airway problem. We're not going to be able to intubate as well. In terms of neck motility, our kids with CP and our kids are going to have shorter necks, so that can lead to less manipulation as well. Also, remember in trauma that we're causing our own decreased neck mobility by stabilizing the C-spine. And remember that any kid that isn't saturating well is just going to lead to a more difficult airway as our oxygenation curve is going to fall off more quickly. So leading back to our central case, our kid is 2 and our differential is more of croup and epiglottitis. What are we more worried about in terms of our anatomic differences that we can optimize this kiddo better? So when I think of a kid with these obstructive pathologies, yeah, sweet. Everybody's going into great. So yeah, the length of her neck is going to be shorter, so that's going to be something to worry about. Our kid with croup or epiglottitis, it's going to be larger, stiffer epiglottis. So we might need to be worried about swelling within the airway. That's going to be more difficult to visualize the chords. We also need to worry about the actual size of the head, and that will kind of go into our positioning that we'll talk about. So the main concept for positioning is that there's three different check marks to make sure they're in the perfect position. The first is going to be their glabella chin plane. So we want the front of the face to be horizontal and parallel to the bed. We want them to have an open neck so they're not obstructed. And we want the ear and the suprasternal notch to line up. There's a few different ones that line up in terms of this last one between their head and the rest of the body, but this is the one that I find the easiest to identify quickly. Some people use the temple bone compared to the breastbone, but it's really up to you just to make sure everything's lining up. So as we go through positioning for this kid, we can kind of focus on what's going to be the best for them to open everything up. So we have the kid on the bed. We start by extending the head. Now that we've done that, we can look at all of our planes. Our glabella chin plane is tilted backwards, so that's not optimized. Our anterior neck space is still constrained and not fully open, so not ideal there. And our ear and our suprasternal notch aren't lined up as well. So even by our simple head extension that we would do for adults, we're not really optimized in any of the three planes for kids. So my next intervention that I do is I'll place a shoulder roll. So with that, our head and our ear are not lined up with where they're supposed to be, but at least we open up the anterior neck space. I like to do this in early resuscitation. More of lining up the rest is going to be to optimize intubation and the rest of the airway flow. But the anterior neck space opening is going to be our biggest impact on the actual ventilation of kids. I like to do this in any sort of procedural sedation or anything where the kid is doing any sort of resuscitation, because it's really going to optimize what we can do externally for the kiddo to make the biggest difference. And lastly, just to line up the kid, we can add our headrest. So with the shoulder roll and the headrest, we're able to get the glabella chin plane at a near horizontal angle. We're lining up our ear with our suprasternal notch, and our anterior neck space is wide open. So this is anything that I will do in a kid who is getting any sort of invasive ventilation in terms of CPAP or BiPAP, because it's really going to optimize the airflow and really optimize the kiddo. If I'm transporting a kid in respiratory distress, this is where I'm going to position them for EMS, so that we're able to have the safest transport for them. Also, by positioning them there, if EMS needs to make any interventions, the kid's going to already be in the optimal position and really takes off cognitive load. In terms of our older children, they tend to turn more into adults where even a simple headrest is going to line up everything. I think this is a really important thing that we often forget about, especially in our wiggly kids. But if our kids are wiggly and active, they don't necessarily need all this advanced position to optimize everything. So by positioning the kid correctly, we can really optimize our ventilation, our oxygenation, and our stability for these kids. It's important to do this not only in the pre-intubation phase, but also in all of our resuscitation phases, just to make sure that they are breathing and ventilating the best possible way. So relating this back to our essential case, how do we want to position this 2-year-old? Yeah, definitely, Gina. We want to get a roll underneath the neck and shoulders to optimize our neck angle and really open up that space, especially in this kid who's going to be more obstructing pathology. If that doesn't work, we can even reposition with the headrest to optimize everything. So in terms of selecting the correct endotracheal tube, the real thought and tradition of what has changed over time is there a difference between cuffed and uncuffed tubes? The idea with the cuffed tubes was that because of where the airway is smaller, that we can really irritate the larynx and cause stenosis over time with a cuff. Now, most endotracheal tubes are using microcups, which have a lower volume and a lower pressure. So there's not too much irritation going on. So the real question is which one is better? And the answer is whatever you have. Um, at our institution, all of our tubes are microcuffed, but we do have uncuffed tubes. It really depends on the situation. I've used uncuffed tubes if my main issue is a laryngomalacia patient who's having more stenosis, swelling, and obstruction. That way we can assess for when the air leak is going to happen and when our intervention is the best. Otherwise, nearly all of our other patients get microcuff tubes. There's not really too much of a difference between which tube works better. It's just more of what's going to be best during the time. And then so for our calculations of our endotracheal tube size, we want to do a better calculation. So there's three different ways that we can do this. For uncuffed tubes, our age divided by 4 plus 3.5 is going to give us the best size. If we don't have any cuff tubes and we need to do uncuffed, you just do age divided by 4 plus 4 to get us that size. You can also use the Broslow tape. This is something that's really useful in terms of resuscitation because it cognitively offloads a lot of different things. It gives us all of our tube sizes, our NG, Foley, chest tubes, and everything else is already calculated for us, as well as our medication dosing. And it's really easy to just call out the medication and then have whoever's looking at the tape call out the correct dose for us. It's also important to know what depth for our ET tube. And one way to do it is age divided by 2 plus 12. So for a newborn kid, we're going to want it to be about 12 centimeters deep, whereas our 18-year-old is going to be 21. And that kind of correlates that any of our 18-year-olds where we're doing a 7 to an 8 size tube, it correlates with our uncuffed tube size times 3 to give us our depth there. This is really important to know in kids because just the size of the trachea within the intrathoracic space is going to be a lot smaller, so it's really important to hit the correct depth. And we can always make quick adjustments just based on listening to the kid after they're intubated. Other important calculations to know is our Foley and NG and OG tube size. You can get these all by multiplying the endotracheal tube by 2, and our chest tube can be multiplied by 3. In terms of medication, there's lots of play as everybody's a little bit different and what they have available. But there's kind of four main things to think about in terms of our medications whenever we're intubating a kiddo. First is our sedating medication. These options include ketamine that you can do at 1 mg per kg, etomidate at 0.3 mg per kg, and midazolam at 0.1 mg per kg. A lot of people, and especially adults, use propofol. A lot of pediatric physicians will stay away from propofol. And it's because that in these kids, we don't know if they have any mitochondrial processing disorders. So propofol can actually impair the electron transport chain in these kids, leading to propofol infusion syndrome and more metabolic stress. If that's the only medication you have, the proponents and the percentage of the population with these things is really low. It's more of just if you have other medications available, it's best to use others. Then you want to use your paralytic in kids. Just remember the contraindications of them. Typically, in my pediatric providers, we'll use more of succinylcholine just because you have quicker on-off if you do end up having a difficult airway. You don't fully take away the respiratory drive. If you have any sort of traumatic injuries, we'll tend to use more succinylcholine. in these kids. That way we can have better neuro exams afterwards because it will wear off quicker. Other options includes rocuronium at 1 mg per kg and even vecuronium at 0.1 mg per kg. And then for adjuncts, a lot of literature has been done to see whether atropine improves our outcomes for kids. The idea with this is because we have lower oxygen saturations, that it's going to lead to more bradycardia. Our evidence for whether atropine is good or not all comes from OR studies on healthy kids. So a lot of our research suggests that atropine doesn't have an effect. However, that's never truly been practiced in the emergency department setting and in really sick kids. So for my practice, I still tend to use atropine in our really sick kids just because it have more of an effect to at least prevent decompensation. Afterwards, it's important to recognize that we are going to need sedation for this kid because any sort of tube intubation is really irritable. Having the tube is not fun. It's also going to improve our intubation. So even if we are using paralytics, they still can feel pain. So making sure we're having some sort of setup in terms of fentanyl, rumifentanil, midazolam, or ketamine afterwards to make sure a kid is no longer in pain and we're able to breathe better is really important to have. And make sure that we have it ready immediately after we intubate as well. In terms of different blades, there's two different types. There's the Miller blade, which is a straight blade. With this, you're going to go in and directly lift up the epiglottis to directly visualize the chords. In terms of the Macintosh or Mac blade, you actually insert it into the vallecula to use all the other soft tissues to elevate it up. So for our kid, this 2-year-old who we are deciding to intubate, what equipment do we want? There is an acronym that I typically use called MARBLES, just to remember if I have everything available. The M stands for monitoring, so we want to make sure we have our pulse ox, our end tidal CO2 up, our EKG, and our end tidal CO2. In terms of the A is airway adjuncts. So I want to make sure I have any oral pharyngeal or nasal pharyngeal airways set up. That way we're able to ventilate the kid better beforehand. In terms of my adjuncts, I want to know, do I want a bougie there? Do I want a stylet? And what other things I want available. The R comes for resuscitation and a rapid sequence intubation drug. So like I talked about earlier, those medications that we want to use. I also want to have everything I have in case we need to quickly resuscitate the kid. Whenever we take away the respiratory drive, we're putting in a large increase on metabolic stress. We are going to make them acidotic. We are going to put their CO2 in rise. We are going to prevent all of our peripheral tissues from being oxygenated. So this is really a really hard stress on the kid and the body for this, which is why we have so many people who crash after we start intubating them. Making sure for the B is our bag mount, our bag valve mask or a BVM, making sure that's ready for ventilating, oxygenating them before and after. I want to make sure I have a laryngoscope. For this kid, I want to use a Miller 1 or 2. Um, the blade preference really comes down to the provider and what you're useful with. In terms of my pediatric intubations, I pretty much exclusively use Miller blades, except in the trauma bays where I'm doing more video scope and I want to have more neck stiffening just to get around it. But it's really whatever you're comfortable with. No studies have demonstrated better efficacy in terms of Miller or Mac blades in kids nor adults. So it's really whatever you're going to be successful with. The E stands for ET2. For this kid, we can do our age divided by 4. So we end up with we're 2, so it's 0.5, and then we're going to add our 3.5 to make 4 for our cuff sizes. And I want all the tubes above and below. Especially in this kid, I want more air on the side of getting a smaller tube because I know there's probably going to be some sort of obstruction. And the S for marble stands for suction. So making sure I have what I typically like doing, a Yankauer and a Decanto, just for help with intubation in terms of what we're getting at. I think Another resource to have available is the American Pediatric Readiness Project. They have a lot of different checklists and other things and resources available when it comes to sick kids in the emergency department. So this is a good website to check out to see if there's anything useful for you guys. They have a whole checklist in terms of intubation similar to marbles, but it goes into a little bit more in depth if you guys want to have that available. And so just a quick video on how to do the Miller video scope, just because this is hard for me to do over the camera. But we see this anesthesia provider going in.
The intubator makes sure the lower lip is not pinched. She lifts upward, avoiding the teeth. She then passes the tube down the right side of the blade, not down the slot. Notice how she holds the tube with her hand resting on the cheek as she withdraws to avoid accidental extubation.
So with the Miller blade, we're going to enter on the right side of the mouth. That we can use the blade to move the tongue out of the way. So I like to start in the right corner and then push the tongue over to midline and then use that to go in. You want to go in very slowly just because with the Miller blade, you have to really optimize where you're going in and where structures you are seeing. So as you go in, you should be able to see the epiglottis to go in, scoop it, and lift it up to get a good view of the cords. If you find that you're too deep, you can go slowly back, and then the glottis should fall down into view. I think in this video, it does a really good job at emphasizing pulling the bottom lip out of the way. Not only is it easier to insert the ET tube without it getting stuck to the lips, it's also a much better way of visualizing because it can nearly double the amount of things you can see in terms of our direct laryngoscopy. And then some other tricks that I find helpful for intubation for these kiddos. If we're using a Miller blade and a straight blade, and you're unable to get the epiglottis just because it's much shorter in kids, it can sometimes be trickier to grab. There's this median vallecular fold or hypoepiglottic ligament that actually supports the epiglottis. So if you're able to seat your blade within that and then push a little bit forward, with the ligament engaged, it will actually pull it up. So you're essentially, instead of using it as the Miller blade to scoop up the epiglottis, you're using it very similar to a Mac blade and elevating it. If you are needing something hyper angulated, especially in kids whose glottis is a little bit more anterior and closer, and we have these really hyper acute angles, you can use a bougie to better get a view. You can also use the end of the bougie to confirm that you're in by feeling for the tracheal grooves. And something that's important if you don't have any stylets available, especially in our smaller cuffs. A lot of our providers, especially in lower resource settings, will use ice water. So if you put the endotracheal tube actually in the ice water, it's going to stiffen it up. So you have the benefit of having a more stiffer hyperacute angle without actually having to have a stylet or bougie to do it. Another trick to do is to inflate the balloon yourself. So you want to actually listen for the air leak to happen, and you want to go just past the point of it being gone, that we're not putting too much stress on the larynx. So another thing that I want to really highlight, and I wanted a full video on how to explain it, is the Neo-T T-piece resuscitator. This is a very good tool that can act as both our BiPAP, CPAP, and even ventilator without actually having to have the machine. All we really need is a finger. You can have an ER tech, a parent, or anybody else do it just because it's very simple to use, but here's a video on how it works.
Here's how to use a NEOT if you don't have one of these fancy devices in your department, ambulance, or helicopter.
This is a NEOT. It's going to come in an off position. I'm going to turn up my liter flow to 10. When I go to check it, I can hear the oxygen, but nothing's flowing. So I'm going to turn this to the yellow. I'm going to set my PEEP, and then I'm going to set my PIP. To set my PIP, I'm going to go up to 25 and use this knob. I'm going to connect this to the ET tube. and I can see my pressures.
Okay. So with this, there's some important details on how to actually use it. Um, Looking at it, it connects easily to any sort of oxygen outflow device. So it can be used in any room and you don't need any special setup in terms of oxygen connectors. You can actually control the PEEP, so it can act as a CPAP. This device doesn't necessarily have to attach to an endotracheal tube. It can also attach to an LMA or even a mask for the kid. So you can add on the CPAP just by adjusting the PEEP and delivering that constant flow. You can also turn this into a BiPAP by monitoring what your pressure after inspired is going to be. So we can go up on that as well. And then in terms of this is attached to an endotracheal tube, it acts as a ventilator. So just by occluding that little airway with your finger, you can deliver breaths at every single moment. So you can coach a parent or a tech or anybody else through the emergency department on how often to deliver the breaths. And then you can also check on the kid every once in a while, see how their end title's doing to adjust all the parameters. So I think something very important that we do in kids and that we forget is using their end tidal capnography because it's not something we typically do in adults, especially in my institution. So in our sick kiddos, getting end tidal capnography early can help identify what's going to be the actual problem. It can also identify how well we're doing from a ventilation standpoint. So we want our end tidal to be somewhere between 30 and 40, sometimes a little bit quicker if sometimes a little bit higher if we're trying to blow off a lot of CO2 in our acidotic kids. In terms of using the device on our right to check to see if we've intubated correctly, in kids, it's not always the best, especially in our really high metabolic stress. It's going to take a while for our end tidal to come up. And it also takes a proportionally higher amount of CO2 in kids. So by doing the direct end tidal capnography monitoring, we can see it earlier and really adjust how we're doing from a ventilation standpoint. It's also important to note the patterns that can show so we can have um, easier diagnostic selection. And tying this all back into the neonatal T piece, if we are actually ventilating a kid, we can make our adjustments there on the impact without having to get blood gases to monitor to see where we are. So we can adjust the rate ourselves if we need to blow off more CO2. We can adjust the PEEP, the PIP, and the FiO2 without a ventilator or an RT. The neonatal T piece can be used for any kid less than 15 kilograms, but really that's more of the manufacturer's guideline. If you're seeing anything, um, yeah, Gina, that's a good point. The peep in the video of 25 is probably going to be a lot more for our kid. Um, so that's a good point. I think the 25 of peep that it was showing in the video is more of the pip rather than the peep. But yeah, I think this is a really good tool that is relatively cheaper than a full ventilator. Yeah, Gina. Yeah, the amount of ventilation and the pressures is definitely going to cause barotrauma in the neonate. I think they were more just doing it for the kid itself in the presentation. But yeah, I think the neonatal T piece is a really good thing that especially if you don't have ventilator or RTs available, um, is going to be a really good useful tool. So yeah, now for our central case, we try to intubate the kid. The obstruction from the swelling is way too high, where we cannot fully intubate them. Afterwards, we are no longer able to ventilate and oxygenate. So what are our different advanced airway things we can do? Yeah, so a trach or a crike. When it turns to kids, we tend to not do trachs in them. This is more recommended for any kid less than the age of 10. Because of our cartilage tissue is so floppy and our landmarks aren't as defined, you have a risk of doing damage in a full tracheostomy. So that's why the cricothyroid airway is the more crucial one to do. So in terms of our different advanced airways, we're just going to touch on nasal intubations.
Before you
Uh,
talk about that, JD, I did want to mention, if anyone listened to the most recent MRAP from last month, they had a pediatric airway specialist come on. This episode should be uploaded on the CMES server within the next month or two. But essentially, a cricothyroidotomy won't work in very small children because their cricothyroid membrane is underdeveloped and it's too small to actually fit an endotracheal tube through, even a very small one. The airway specialist that they brought on this MRAP episode suggested that if you're not getting good success with needle jet ventilation in someone very tiny who's too small for a cric, a crash trach is an option, but these are all things that you shouldn't be doing if they're not within your scope of practice. And it's best to have anesthesia or surgery, ideally pediatric surgery or ear, nose, and throat available at the bedside if that's something you have available to you. Go ahead, JD.
yeah. So nasal intubations are something that is not done in the ER or ICUs generally, but often the OR just in terms of any sort of mouth trauma or interventions in terms of the oral area. Um, so for this, just quickly touching based on it, you're going to do the same thing as an endotracheal intubation, except you're going to start through the nose. So I have a quick video on kind of how exactly it happens just for our own education. So you're going to start out with dilating it up with any sort of oral for
Which has been warm, lube it up,
here.
and we're gonna have to stick it into the nasal pharynx. The next step is to perform laryngoscopy. When using your McGills, you grab the tube proximal to the cuff and direct into the trachea.
So yeah, it's going to be similar to an endotracheal in our normal intubation, except you're going to start in the nose. So a lot of times people dilate up with the nasal pharyngeal airways just to allow it to go in quicker. A lot of people will do any sort of nasal vasoconstrictors beforehand to minimize any blood or irritation to the area. You then slide the nasal tube into the pharynx, and you use your McGill's and laryngoscope to direct it between the cords. Again, not something that is typically done in the ER, but just something to be aware of. Use the same size French as our endotracheal tubes, except you're going to adjust for the length, just because they're specific nasal design tubes. And now for a needle cricothyrotomy. We are going to do this for anybody that we are unable to intubate and someone that we cannot ventilate or oxygenation. For this procedure, how we do it is we want to prep over the area, making sure that we're not introducing any sort of local bacteria. We want to identify our cricothyroid membrane. And then you insert an angiocath in. You want somewhere between 12 and 14, but essentially the largest one you have available. You want to insert it around 30 to 45 degrees and aspirate as we do it. As soon as we get any sort of airflow, you then want to advance the catheter in. How you attach this to any sort of gent ventilation or whatever we have available depends on what you have available. There's multiple different options. The best way to know what will work for you is what you have. And making sure we identify what you have in the ER before you actually need to do this. So a couple different ways you can do it. You can attach a 3.0 endotracheal tube adapter over into the angiocath to attach it to the bag ventilation mask or a jet ventilation setup. You can use a 3 ml syringe to attach to the needle and then a 7.0 endotracheal tube adapter. Or if you don't have any of that available, you can attach a 10 ml syringe and actually insert the endotracheal tube into it. And then you can cut it down depending on what you need. This is not a fun thing to do. This is something I've never done on a live kid and hopefully something I never have to. But it's important just to know what you have so that we can be prepared before it happens. This all gets attached to a BVM or jet ventilation setup, but it's important to recognize that this is not something that will provide ventilation, or yeah, it won't be able to provide ventilation, but it will be a way to supply oxygenation. Ideally, this is something that can only be used for less than 45 minutes until we can get to a definitive airway with either ENT or surgery, whoever we have available. But if this is our last term resort, that's something that we need to do just to temporize until the meantime. So here's a quick video on how this is actually done. So like I said, you're going to identify the area. In this case, I'm assuming that they prep beforehand. Um, After you've identified it, okay, good, they did do prep. You're going to insert your needle at kind of the 45 to 30 degree angle. Typically, I try to do as low as possible to ensure that I'm getting it placed directly towards there. As we start to aspirate air, you can advance the angiocath in. And then you have to dispose of your needle, as we all do, and then have the quick setup available. Making sure we secure that in place so it doesn't come out if the kid starts to move, and then applying whatever setup, if that's a jet ventilation setup, or even a BVM can be used in a pinch to supply oxygen directly into it.
So typically we like to go through the Ugandan and Gambian clinical guidelines, but I will say, as you can see on the next slide, that there isn't too much in either of the clinical guideline documents. You can advance the slide, JD. Primarily, there's a focus on airway management in the newborn, which we didn't dive into in detail. We talk mainly about the pediatric patient. There's a lot of overlap here, but they emphasize the same points that Dr. Duhamel went through earlier, that positioning is key. So that ear to sternal notch positioning, using a towel roll under the baby's shoulders, since the head is much larger in a child as compared with an adult. And if there are secretions that are obstructing the airway, you can certainly suction, but aggressive suctioning is no longer recommended for babies. And then for someone who has meconium in the mouth, and if it's obstructing the airway, that definitely needs to be suctioned, but avoiding deep suctioning or prolonged suctioning, since that can actually cause a vagal response or obstruct the airway in babies. And then in terms of the bag mask ventilation, which a lot of you emphasize that you don't have a T-piece resuscitator. So it's important to have very good technique with your bag valve mask ventilation. Remember that you need to pick an appropriate mask size and that it needs to cover the chin, the nose, and the mouth. And it's ideal if you can have one person do two-hand ventilation. So one person doing a jaw thrust while another person does the actual bagging, since you'll get a better mask seal that way, as opposed to one-handed mask seal with the EC clamp. You can move forward. They do talk about RSI, or rapid sequence intubation, in the Ugandan clinical guidelines, but there actually isn't a mention of what to do if the airway is difficult, and there isn't a specific discussion on the anatomical and physiological differences in children compared to adults. Similarly, with the Gambian clinical guidelines, go ahead. Yep, right there. Basically, they cover the airway management in the newborn, but they do not mention what to do in the older child who's having a difficult airway problem. So there is mention multiple times of opening the airway and folks who are dealing with an airway issue, but not what to do after that point. You can advance the slide. So I think the key thing here is figuring out what resources are available to guide your airway management plan at your institution. So on the next slide, we have some discussion questions. I know we're running short on time, so I'm going to let Dr. Duhamel kind of moderate these questions while I post the post-participation multiple choice questions that were requested by you in your prior surveys. People gave us feedback that they wanted multiple choice questions. So let me put those up.
Okay. So a couple questions that I kind of want to discuss here is, what resources do you guys use to guide your airway management plans? It's like, do you guys have a setup in terms of checklist before you intubate? What are your guys' requirements on how you decide when to intubate? What kind of stuff do you guys use?
Are there any institutional protocols in terms of airway management? Since we mentioned that there aren't a lot of details in the clinical guidelines nationwide that explain how to manage an airway, I'm curious if any of your hospitals have a specific airway management plan for pediatric patients. Okay, feel free to answer in the chat. I know we've already discussed multiple times that there are resource challenges that make it difficult to get the ideal airway situation. Some people mentioned not having the equipment we discussed. Other folks mentioned having to kind of guess or ballpark what size equipment they would use for a child. If there are other resource management issues, we would love to hear about them in the chat or out loud, how you get around those, how you overcome those obstacles to give the best care for your pediatric airway emergencies. And thanks, Nazra. It looks like you use the Ugandan clinical guidelines and then hospital care for children. I'm actually not familiar with that one. I'll have to look that up. Is that at your institution or is that like a nationwide protocol? Oh, it's from the WHO. All right. Good to know. I just looked that up. This looks pretty good. Thank you for that tip. All right, Dr. Duhamel, I'll let you move forward to the take-home points while we leave the multiple choice questions open.
Yeah, so some take-home points from this presentation are that pediatric airways are going to be anatomically and physiologically unique. Proper positioning is critical for successful airway management in terms of before we intubate and during we intubate. Equipment selection must be age specific, whether we're doing calculations or going off Braslo tape or however we get it, just making sure that we're specific for the child and their size. We need to anticipate and prepare for difficult airways in terms of what other things we have available. But overall, we need to optimize our pre-oxygenation and use rapid sequence intubation thoughtfully.
It looks like someone has a question. Go ahead and speak out loud, or you can also write in the chat.
Okay, thank you so much, presenter, for your excellent delivery. I just have a few add-ons or comments to make on some of your submissions. The place of tube monitorings and tube care during intubations is very, very important. So it's not a
Emmanuel, I think your reception might be going in and out. Would you be willing to type your key points in the chat?
Applications to intubation must be duly categorized as at the point of decision making. Those are some of the spotlights that I want to make. Make sure that if you are not comfortable, you get a trained hand to do the intubation for you. Thank you so much. Over to you, Duhamel.
Thank you. Otherwise, I believe that is it. Dr. Pelletier?
Yeah, I'm going to end the poll and just quickly go over the answers to these multiple choice questions. Thank you guys for participating. You should be able to see the correct answers, hopefully, on your screen. I just shared the results. And these answers will also be in the post-journal club summary that we share on WhatsApp. And a reminder that we have a YouTube site, and I will post the video link as well. And if you don't have enough data to watch the video later, you can always read the journal club summary, and that will get uploaded onto our CMES platform too. So what is the most common reason neonates are obligate nasal breathers? The majority of you got that correct. So the tongue is proportionally larger and the soft palate touches the epiglottis. So lungs are not typically underdeveloped if someone is full term. Their epiglottis is definitely large, but it's not going to cause the obligate nasal breathing. And then their nostrils are usually bigger than ours relative to the size of their head. Question 2 was which formula is commonly used to estimate the correct size of an uncuffed endotracheal tube in children? And the answer was age divided by 4 plus 3.5. I do want to emphasize Dr. Duhamel's point that having a Broslow tape or an application like PD-Stat or some sort of badge buddy that you can put on your hospital badge, something like that to remind you of appropriate equipment sizes for children is really critical, because in the moment it helps you cognitively offload and not have to stress about taking care of that child, so you can focus on more important tasks like their actual resuscitation, rather than being stressed about what tube size do I need, or what size chest tube, or what size nasogastric tube. That way you can actually focus on the patient care. Question 3, what is a key anatomical difference in the pediatric airway compared to adults? And the answer was that their occiput is larger and that affects positioning. Remember, for adults, often we'll need to put a towel roll under the occiput because of our anatomy, compared to a child who might need a towel roll under the shoulders in order to optimize ear to sternal notch positioning for intubation. Question 4, which of the following is a sign of impending respiratory failure in a pediatric patient? I will acknowledge that tachypnea, nasal flaring, and stridor on inspiration are all signs of respiratory distress, but as Dr. Duhamel highlighted, drowsiness and fatigue, so being about to wear out because of their level of respiratory difficulty, is a sign of impending respiratory failure. So it should make us very nervous when someone is becoming drowsy and fatigued and can no longer maintain their elevated respiratory rate or that accessory muscle use, because at some point their body will give out and they might go into cardiac arrest. So just keep in mind, drowsiness and fatigue is the most critical sign of impending respiratory failure. And do make sure in those situations you're checking a glucose, looking for other reversible causes in addition to their hypoxia or hypercapnia that's causing them to be drowsy, since that would be reversible. And then number 5, what is the first step in troubleshooting a failed intubation attempt in a child? And the answer would be recheck positioning. I would hold off on a needle cricothyroidotomy until all else has failed. That is definitely a last ditch option. And like Dr. Duhamel highlighted, it's not a long-term option, since that allows for oxygenation, but not ventilation, meaning oxygen can get in, but CO2 cannot get out. I want to thank everyone so much, especially Dr. Duhamel for presenting, but also to all of you for participating, for asking questions and participating in the chat. I'm going to post the survey link one more time. Your feedback on these surveys is critical to help us improve these sessions to make them better for you. Thank you guys, everyone, for being here, and I hope you have a great rest of your day. Thanks, JD. Appreciate you.
Thank you.
Well done, JD. Well done, Jess.
Thanks, Emmanuel. Good to see you.